Hello, guys. Welcome back to pediatric nursing, and it has come to that time where we are finishing up this semester with chapters 33, 35, and 36. These will consist of cognitive and psychosocial alterations along with child abuse and neglect. Alright, let's start with chapter 33, which will go over our cognitive alterations. These next three chapters will be like the last six chapters that you reviewed on your own. I will go over topics to look at and what specifically to review in your text, as well as any relevant examples that you may see on your examination. First, we'll look at mental retardation, which starts in your text on page 1262. I do want you to know what it is defined as, and then go ahead and review any pathophysiology that you may need. And I want you to mainly pay attention to your clinical manifestations, any treatments, and diagnosis. Of course, what we always do focus on is our family teaching and how this will affect the child. While you're looking at your diagnosis, I do want you to look at the intelligence quotient, or what is known as your IQ. You do want to know what is done during that time and how those are determined. Also, you can look in your text on pages 1264 in table 33-2, which gives you the common test for the diagnosis of mental retardation. I also want you to go ahead and review the family's response to having a child with mental retardation. It can be different depending on the age of the caregiver and the age of the child. Also, box 33-1 in your text on pages 1269 is relevant. It goes over the grieving process for caregivers with a child with an impairment. And you may remember these from your mental health class or even way back in sociology or psychology. We go over denial, anxiety, fear, depression, guilt, and anger. So do review those. And then we will look at institutionalization and out-of-home placement. What I do want you to recognize when we talk about this subject is that it is never the nurse's responsibility to make the decision regarding placement of a child. It is, however, the nurse's responsibility to offer information about the options that are available. Information about out-of-home placement is usually provided when the caregivers request it, but it is not inappropriate to broach the subject when the child has achieved certain developmental milestones, such as the end of high school. Also, go ahead and review Special Olympics and how those are done and what countries they are offered in and the criteria. There is a nursing alert in your text on page 1271, which goes over cardiac defects in neonates with Down syndrome, which is the next topic that we will look at. So, of course, you want to know what Down syndrome is and how it affects the child. If you need to, review your pathophysiology, mainly looking at your clinical manifestations and what you will see in a child with Down syndrome. Mainly, I want you to know that they'll have the muscle weakness and the hypotonia, as well as the large tongue and the small nose and depressed nasal bridge. The epicanthic folds, which are your small skin folds at the inner corners of the eye, is also one thing that you want to look at. Also, you want to go ahead and look at the diagnosis and treatment, of course, and you want to know that there is no cure for Down syndrome. So, of course, you want to go ahead and review the nursing management and your role as a nurse and how you can help the caregivers and the child. Also, it is important to look at the society's response to children with Down syndrome. There is a family teaching box in your text that goes over respiratory infections in children with Down syndrome. You do want to look at that as well. And that will take us into the autistic spectrum disorders. There are 5 autistic spectrum disorders, and they are sometimes called the pervasive developmental disorders, one of which is autism, Asperger's disorder or syndrome, Rett syndrome, childhood disintegrative disorder, and pervasive developmental disorder, not otherwise specified as PDD-NOS. So I do want you to look at those. The main ones that you will focus on, of course, is your autism and your Asperger's disease. You can review the incidence and etiology as well as any pathophysiology that you may need. Go ahead and look at those clinical manifestations and understand what is manifested in a child that has autism or Asperger's disorder. Of course, you want to know how it is diagnosed and the treatment regimen for both of those. And you want to know that there is no cure for autism. Of course, nursing management, how are we going to help these parents and children cope with this disease or this disorder? Also, you can look at the nursing tip in your text on page 1281 that goes over ideas for medicating an autistic child. Family teaching is always important, so don't forget to review that information as well. That moves us on to Fragile X syndrome, and you want to go ahead and review the pathophysiology and clinical manifestations if needed. Okay, now we'll finish up with where we left off, and I just want you guys to make sure that you do review the clinical manifestations for autism as well, and looking at your diagnosis and treatment. And I think I remember saying that there was no cure for autism. And of course, you want to look at that nursing tip on 1281. And then that takes us over to Fragile X syndrome. So again, I do want you to review your etiology and incidence and your pathophysiology if you need a review. Go ahead and look at your clinical manifestations and how the child with Fragile X syndrome actually appeared, especially if you are looking to do a nursing assessment. You also want to look at diagnosis, treatment, and of course your nursing management. You want to know how you as the nurse will care for a child with this syndrome if you do come in contact with a child with this disorder. And looking at additional cognitive alterations, one of which is your fetal alcohol syndrome, and you may have talked about this within your maternity class. You do want to review what it actually is. It is a cluster of behavioral and cognitive abnormalities, so you do want to review kind of what it is. I know it is obvious for its name. And you do want to look at the clinical manifestations because an infant versus a child with fetal alcohol syndrome may exhibit different characteristics, especially on admission or during your nursing assessment. Please do review the treatment for this as well. And that will conclude Chapter 33, which does go over your cognitive alterations. I do want to look at a few examples, of course. Those that are suspected of chromosomal abnormalities, they should receive chorionic villi sampling. You may remember that from maternity as well. Those are things that they do while the mom is pregnant. You also want to note that the child with PKU, I know we didn't talk much about that, or we didn't touch on that within this chapter. You may remember that also from maternity, they have to be on a special diet. So you want to note when you are doing teaching for a child that has PKU, and this is not just the 5 blotted blood tests that they do. There is a disorder known as PKU, so I don't want you to think that I'm trying to trick you or anything, but there is a disorder known as PKU. So they are on a special diet. So you do want to note that when you're teaching the parents about this disorder, that their child is not able to eat potatoes or bananas, which myself, I love bananas, so this will be a problem. So you do want to teach parents about that because those are one of the first fruits that they actually introduce to the infant. So you do want to make sure you note the family teaching on that. You also note when deciphering between minor and major disorders. A minor one would be a webbed neck. And this is also a sign that is characteristic within a child that has Turner syndrome. So you do want to be able to note the differences between what are minor conditions or disorders versus your major ones and what they actually correlate to. So your web neck does correlate to Turner syndrome, but it is known as a minor disorder. Now moving forward, if the child does have a low IQ, one of the tasks that they may find challenging is something like brushing their teeth. Things that we take for granted as being so easy could be very complicated for the child with a low IQ. If the child does have a learning disorder, one of the facts that should be included in the discussion is that his or her disorder is caused by a difference in brain architecture. So you do want to explain it to the parents so that they understand and break it down in terms that they can comprehend. When we look at the child with Down syndrome, they should adhere to their dietary needs, especially during infancy. This does not mean that they should not maintain a good healthy diet just because they have a chromosomal abnormality. If the child's diagnosed with severe hypotonia, which we know is one of the clinical manifestations of Down syndrome, a good nursing diagnosis would probably be grieving related to the child's poor prognosis or imbalanced nutrition, less than body requirements related to the effects of hypotonia. If you do not know what hypotonia is, please do look it up. I will not tell you. So do look that up and review what it actually is and how it actually affects the child. Other characteristics of Down syndrome will include that flat facial profile, a large tongue as reviewed earlier, simian creases, and of course your epicanthial folds, which I did talk about briefly as well. Those are also found in your textbook. If you're looking at assessments, the child who would be suspected of autism is the one whose reaction to the caregiver leaving him is to calmly repeat saying bye and the person's name. So let's say their dad is leaving. Usually they have separation anxiety, but the child with autism may constantly repeat bye-bye Will or bye-bye Jill, and they may constantly repeat that, whereas a normal child with normal cognitive development will be anxious because of the separation and not so calmly dismiss the parent or caregiver. As the school nurse, you would suspect autism if the child is not participating in the same activities at the same time as their other classmates and is ignoring the authority figure in the room. So if the other children are playing or eating snacks and the autistic child is off in the other part of the classroom, rubbing on the walls, not paying attention, ignores the teacher when she or he ask them if they want a snack. This would prompt the school nurse to suspect that the child is autistic. You do want to note the differences between a child with autism and a child with conduct disorder. So you have to note the difference. There is a fine line, and a lot of teachers and school nurses are trained in this so that, these kids aren't misdiagnosed or, undiagnosed for a long period of time just because they're thinking it is a conduct disorder. If the child has social issues, you want to make sure that you as the school nurse or the healthcare provider minimize stimuli that exacerbates the child's undesired behaviors. You can also teach that to the parents or caregivers. When we look at a child that has mental retardation secondary to the Fragile X syndrome, you want to note that if it is a boy, he will pass the gene to all of his future daughters, who will then become carriers. So they will be carriers of that disease or disorder. And lastly, when looking at Tay-Sachs disease, which we did not mention within this chapter, I do just want to touch on that just briefly. When you do have a child with Tay-Sachs disease, you want to note that that child will develop normally, until they are about 6 months of age, and that is when you will start seeing developmental delays appearing. And with that, that will conclude Chapter 33, Cognitive Alterations, and we will move forward to Chapter 35, which goes over our psychosocial alterations. Okay, guys, now we're on Chapter 35, which will go over our psychosocial alterations. This starts in your text on page 1346. I do want you to go ahead and look at and review your treatment modalities when we look at our psychosocial alterations. These include, but are not limited to, your individual therapy, family therapy, group and play, as well as art therapy. I do want you to review those and see how each one actually helps the relationship of the caregiver and the child coping, and the actual child with their disorder or alteration. I also want you to look at using drawing to diagnose, which is one of your nursing alerts in your text on page 1347. And that moves us forward to ADHD, or Attention Deficit Hyperactivity Disorder. I do want you to review, of course, what it is and how it affects the child. You can review your etiology and your incidents if you need to, but do pay closer attention to your clinical manifestations, your diagnosis, and of course your treatment. Look at your nursing tip in your text on page 1348, which goes over conditions producing behaviors similar to ADHD, because most oftentimes these children are misdiagnosed or undiagnosed for long periods of time, depending on what the healthcare providers or physicians are actually looking for upon assessment. So, within your nursing management role, I do want you to look at planning and implementation, and note what a drug holiday is and how those are done when it comes to taking the children off of their medications to see their effectiveness, and if in fact they still need the medication. You also want to look in your text on page 1351 at box 35-1, home interventions for the child with ADHD. And lastly, of course, we want to pay attention to our family teaching and how our caregivers will monitor and take care of their child with this alteration. Then we look at mood disorders. These are also referred to as your depressive disorders, and they are common among children and adolescents but are frequently unrecognized. So I do want you to look at the two types that they describe within your text, which is your bipolar disorder and your depressive disorder. You can review your etiology and pathophysiology if you need to, but do pay closer attention to your clinical manifestations, diagnosis, and treatment. You also want to look at, when we pay attention to our nursing management, I do want you to look at planning and implementation, as well as your family teaching. Note that for these alterations, family teaching and support, as well as your nursing management and any interventions that are done, is very important. You want to look at sleep, hygiene, and depression, which is found in your text on page 1355 in box 35-2. We will now look at suicide. You need to understand what it is and how it actually affects the child. You can review your incidents and etiology as well as your pathophysiology, but as said earlier, want you to pay closer attention to how it is actually diagnosed, how your children are treated, and the actual nursing management for this disorder or alteration. Some of the important key essentials to look at is your nursing tip in your text on page 1356, which goes over interviewing an adolescent, warning signs of suicide, which can be found in box 35-3, as well as the decision to actually commit suicide, which is found in the nursing alert. Lastly, I want you to look at your nursing management. These are crucial things that you as the nurse can do, or what you can look for in these children that exhibit signs and symptoms when it comes to suicide. And I also want you to look at box 35-4, which are reasons for hospitalizing a child or adolescent for suicidal behaviors. Of course, you want to pay attention to your family teaching and how the caretakers and caregivers can cope with their child and understand their child and actually seek help for their child if they're thinking of having a suicidal attempt. Next, we'll look at our anxiety disorders. You want to understand what they are, one of which that affects our children is the separation anxiety disorder. So you want to know what that is and how that actually affects the child. Another major one that you will notice if you're going to be in the pediatric setting is children with social phobia or even school phobia. We also have our generalized anxiety disorders, and we do have some children with that disorder. And as many other disorders, it goes undiagnosed or, misdiagnosed because of other things that may be going on with the child. So you do want to look at what those disorders are and how they're described. And my personal favorite is the obsessive compulsive disorder. I would think that I have that myself. I self-diagnosed it quite some time ago. So yeah, but mine isn't as bad, and of course I'm not a child. So if you have gone over this disorder within mental health, you may notice that quite a lot of people actually have this disorder, and there are medications for it, of course. But if it is not bad to where, it is disrupting life and preventing the child or adult from doing their normal daily activities, then most times medications are not needed. So do look at those and decipher between the four of them. You do want to look at your clinical manifestations, of course, and how the child will exhibit those, as well as your diagnosis and treatment. When we look at nursing management, of course, we want to look at outcome identification. We want to know what the child will be able to do if they actually have this disorder and how they're going to be able to cope with this disorder and actually live their lives. So we do want to look at family teaching as well, because we want to teach the parents how to take care of these children. It is not all the child by themselves, especially if they're smaller. When they get into adolescence, of course, we give more permission and power to the actual adolescent child. But we do want to include those caregivers and caretakers in limit setting and controlling the atmosphere and the environment that the child may be in. And lastly, you want to look at post-traumatic stress disorder. And I know we don't really think about this with happening with children. We think of it more as happening with adults, especially those that have served in the military or with those that have been abused or raped within their childhood. So now you can see how having something happen within the childhood can, in turn, affect the child as a child and not so much as an adult, but how it can carry through with them to adulthood. So I do want you to look at your post-traumatic stress disorder, also known as your PTSD, any clinical manifestations, your diagnosis and treatment, as well as your nursing management. And now I want to look at a couple of examples before we finish up chapter 35. And some of these terms that I will speak on are not in your text, but I do want to bring them up and briefly talk about them a little bit. So another one of our psychosocial or cognitive disorders or alterations that I do want to bring up is Tourette syndrome. So if a child has Tourette syndrome and they are of school age, if you as a school nurse want to educate their teachers, you do want to let them know to allow the child to have breaks when tics occur, and that is when they have these outbursts or, you know, these repetitive motions or things that they're doing. The child needs a break, so they may not be able to sit in class for 90 minutes without having a break. So you need to teach educate the teachers to allow these children to have a break when needed, and allow them to use a tape recorder to take notes. And these are one of the things that is considered a special condition for the child, because a lot of schools do not allow recorders of any sort. But if the child has special permission due to their disorder or alteration, then that is when it is able to be used. And you also want to note that children with Tourette syndrome almost always have ADHD as well. So with them being in class, it would be helpful to have a tape recorder as well, so that they can too succeed within their school. Now, you want to know if the child has ADHD, recommendations that you as the nurse could make to their caregivers would be to paint the child's room in pastel colors. Be certain that you have the child's attention before giving any instructions. Ask questions when the child has trouble relating to a story. And of course, break down any chores in a step-by-step manner so that the child understands. Also, a child with ADHD may exhibit impulsivity, inattention, distractibility, as well as hyperactivity. If the child is on medication for this ADHD, you want to note that the medication may cause a decreased appetite, so the child may not want to eat. And we know that if they're diagnosed earlier on, our children are very finicky eaters anyway. So you want to teach the caregivers what manifestations to look for, especially if starting on a new med. So if the child is diagnosed with ADHD, and let's say they're on Ritalin, if they've been on the medication for about 6 months and the parents state that it is not working, make sure you as the nurse or healthcare provider set that child up with an appointment as soon as possible. You want to get those parents and that child in front of you to actually observe what is going on and talk to both the child and the parent. Because it may not be that the medication is not working. It may be that the child isn't taking it. It may be that the child is not on the correct regimen. And there are a number of factors that may be going on. So you do want to schedule an appointment as soon as possible when we look at treatment regimens and them not working. A child who exhibits ADHD, especially a school-age child, they may leave in the middle of class without permission. They may also disrupt others. And if we are on the outside looking in, we could suspect a conduct disorder if the child exhibits physical fighting all the time, if they actually initiate physical fighting a lot, truancy, or even if they've been arrested for arson. Those are our children that we tend to worry about, and they have conduct disorders that we need to get under control while they're in their earlier stages versus letting it go when they're smaller, and then as they get older, they start killing people. So, it is not normal to kill cats and cut open rabbits and put them on display. So things like that are weird or not normal, not everyday things happening, then we need to report it, especially if it is a child doing that. That is not part of the developmental milestones that we want them to exhibit. Okay? Also, if the child has behavior issues, you want to focus the child's attention on that negative behavior and praise the good behavior. You want to focus that attention. I know you think it would be opposite and not focus the attention on the negative behavior, but you do want to you want the child to realize that, yes, this is a negative behavior and I should not be doing it. It should not fully be ignored. As in when we spoke about the temper tantrums and ignoring the child. If this child has negative behaviors, we want to point them out and let them know that these are negative behaviors and that they should not be doing this. But in turn, you do want to make sure you give good feedback and praise them for any good behavior that they are doing. You also want to know that one way to tell between a defiant disorder and a conduct disorder is if the child has frequent temper tantrums. So there's a very fine line between a lot of these disorders, and so it takes a very skilled healthcare provider to decipher between them, and that's why a lot of children go undiagnosed or misdiagnosed for quite some time. So, if a child has depression and is on medication, the parent should tell the doctor if they demonstrate a loss of interest. This can mean they're at risk for pre-suicidal behaviors. And children that are placed on antidepressants, especially at an early age, are at risk for suicide. So we do want to make sure we let our healthcare providers know about that, and we want to teach our parents that as well when these children are started on these types of medications, especially at an early age. You also want to note that children who most exhibit separation anxiety disorder is a school-age child. If these school-age children do not want to stay the night at a friend's house, especially a friend that they're close with, this could mean that they have separation anxiety disorder, because when they get into the school age, pre-adolescence, and even the middle adolescence, late adolescence, they depend on their friends. So if they are not wanting to stay with their friends, they're not wanting to hang out with their friends, they only want to be around the parent or caregiver, then we can suspect separation anxiety disorder. Now, for a child with separation issues, play therapy may be a way to assist the child in socializing with the therapist. If a child is then bipolar and taking lithium, they may exhibit these signs: excessive urination and thirst, tremors, nausea, weight gain, as well as diarrhea. And you can see just from those clinical manifestations how they are similar to what? Diabetes. So it is sometimes easy to misdiagnose some of these disorders or alterations because of the clinical manifestations that may be exhibited in the child. You also want to note that if the child is depressed, you want to ask them to sit and express their concerns, or you want the parents to sit and express their concerns. We do want to exhibit therapeutic communication. Lastly, last couple of things I want to speak on is if the child is suspected of hurting themselves due to depression, as the nurse, you want to ask them how would they hurt themselves, not necessarily why they're hurting themselves. And lastly, you want to note that if the child who often has negative thoughts, they should receive therapy to replace those thoughts. And this can help because we don't want them having suicidal ideations or things of that nature. So this is known as cognitive therapy. And those type of therapy sessions actually work for the children that have these cognitive and psychosocial alterations. And we will finish up with psychosocial alterations on the next slide. Okay, let's finish up with psychosocial alterations, and that will bring us to substance abuse, which is in your text on page 1362. You do want to review, of course, what it is and how it is defined, especially for a child. You want to review any incidents or etiology that you may need to, and you want to pay attention to your clinical manifestations as well as the pathophysiology. Of course, we never want to skip over our treatment, diagnosis, nursing management, and of course our family teaching, because those let us know how we as nurses can care for the child and the caregiver or provider for that child. We also want to know the important role we can play as the nurse in preventing substance abuse and any treatment that we as nurses can help and teach the caregivers about so that they can carry on with it while the child is at home. Also, we want to look at eating disorders. There's two that we will look at, anorexia and bulimia. You do want to decipher between the two and how they are different. You can look at the incidence and etiology as well as your clinical manifestations and pathophysiology, your diagnosis and treatment, as well as your nursing management. Do note the differences between the two disorders. And lastly, you want to look at failure to thrive and what the term actually means. When we talk about the child, you do want to look at things that can affect the incidence and etiology of the child having failure to thrive, and those are listed as bullet points in your text on page 1370. You also want to look at the clinical manifestations and pathophysiology as well as your diagnosis, treatment, and nursing management. And with that, that will end chapter 35, which goes over your psychosocial alterations. I do have a couple of examples when we look at the child with anorexia and bulimia, as well as our failure to thrive children. So if you have a child that has anorexia, you want to note, especially on assessment, that they may have soft hair on their backs and on their arms. And this is like the very fine hair that we find on a baby, and it's called lanugo. And this is especially seen at adolescence. So you want to note that this is not a normal occurrence. Especially at adolescence, it is normal for the child or the infant to have lanugo as an infant. But when the child is in adolescence, this is not normal, and this will be exhibited in a child who has anorexia. They may also refuse food frequently, and they may also exhibit a murmur and cavities when we're looking at assessing these children. So one of the major things that you want to teach the parents or caregivers is that if they are refusing food altogether, they require hospitalization, because we need to fix these fluid and electrolyte imbalances, especially. You want to suspect bulimia if the child has calluses on the back of their knuckles, and this is usually from forcing themselves to throw up. Like I said earlier, their highest priority, or your highest priority as the nurse, is to correct those fluid and electrolyte imbalances, because if you remember from the fluid and electrolyte imbalance or alteration chapter in this course, you will see that those can cause very, very significant changes in the child and even death if they are not taken care of in a proper time fashion. And lastly, I want to look at failure to thrive. If a child is at risk, you want to ensure that you as the nurse engage with the child in a dialogue regarding their feelings about self and personal appearance. So, I know you may think of failure to thrive as just in infancy or even in toddler stages, but this can progress through school age and even our adolescence. They can have failure to thrive. So you do want to how to talk to the child and how to assess for this disorder. And usually if they're in a older age group, so let's say your preschool, your school age, your adolescence, then of course they will have already had this diagnosis. But if they went undiagnosed or even misdiagnosed, you as the nurse or healthcare provider may pick up on this. And with that said, this will now conclude chapter 35, which goes over our psychosocial alterations. Okay, last but not least, we come to chapter 36, which goes over child abuse and neglect. And this starts in your text on page 1380. I do want you guys to review what child mistreatment is and how it is a major public health crisis and how it actually impacts the child of today. I also want you to briefly review the theoretical approaches to child abuse and neglect, and those go over the sociological model, the social interactional system perspective model. And in your text, I do want you to look at Table 36-1, which goes over the risk factors for abuse. Also, you can look at the attachment model, which is in your text on page 1384, as well as that nursing alert that goes over signs of abuse. Lastly, the box 36-1, which goes over patterns of attachment. And then we'll look at the types of child abuse. You want to note the differences between them. Of course, the first one that is listed is your physical abuse. You want to go over those clinical manifestations, especially for that physical abuse, and what you may see in the child that exhibits physical abuse. You also want to review your shaken baby syndrome. This is important, and you may remember that from earlier in the chapters that we reviewed, as well as in your maternity class. You may have even talked briefly about it within your mental health. I do also want you to look in your text on page 1388, table 36-2, date estimation of bruising in the abused child, as well as box 36-2, common signs and symptoms of shaken baby syndrome, and that nursing alert as well, infants at greater risk for shaken baby syndrome. You can also look at those clinical manifestations for psychological. Of course, your diagnosis and treatment, and never forgetting your nursing management. You also want to look at box 36-3 on page 1389 that goes over behavioral indicators of physical abuse. Also, things that are good to look at in your text on page 1390, boxes 36-4, 5, and 6. Getting a history of physical assessment, looking at those categories for child abuse, your psychological assessment, and your interpersonal assessments, as well as interviewing the child, interviewing the caregivers, and warning signs of Munchausen syndrome by proxy. Those are found in your text on page 1391, boxes 36-7, 8, and 9. So that leads us into Munchausen syndrome. You want to know what it is and how it is separate, or how it is considered a separate form of physical abuse. You want to know what the difference is in Munchausen syndrome by proxy and Munchausen syndrome. You do want to note the differences. You want to look at the nursing management, of course, and then you want to look at childhood abandonment and neglect. Of course, noting what it is, nursing management, your psychological abuse. Also, table 36-4 in your text on page 1395, which goes over types of neglect and their manifestations. And that carries over to pages 1396 as well. Also in your text on page 1397, box 36-10 goes over signs and symptoms of neglect, as well as box 36-11, behaviors of adults who psychologically abuse children. Also, you want to look at your sexual abuse and assault, statutory rape, that is also included in there, and child molestation. You also want to look at those boxes in your text on page 1398, which goes over characteristics common to psychologically abusive parents and indicators of psychological abuse. You also want to look at box 36-14 and 15, which goes over when sexual abuse is suspected, and questions to ask if sexual abuse is on page 1400, which goes over manifestations of sexual abuse in children. You also want to look at the long-term consequences of child abuse and neglect, and of course, most importantly, prevention of child abuse and neglect. You also want to look in your text on page 1404 at common activities for prevention and protective factors associated with prevention of child abuse. And these are found in boxes 36-16 and 36-17. And lastly, you want to look at legal issues related to child abuse and neglect. And of course, most importantly, what we do as nurses is reporting that child abuse. Of course, look at the nursing tip in your text on page 1406, which goes over the legal issues and child abuse. You want to note, most importantly, that we as nurses, again, have to report any suspected child abuse. You would rather report child abuse and it be wrong, or the allegation to be wrong, than to not report it at all and the child end up suffering. So now we want to look at a couple of examples. So if you are providing a program on sexual abuse, you want to note that sexual behavior correlates with the child's developmental age. So you want to not talk in terms that the child may not understand. So if the child is an adolescent, you can talk in more adult terms, whereas if the child is preschool or even toddler age, you cannot use those same terms. If you are a nurse caring for the child in the ER and suspect that abuse has occurred, you want to suggest to the MD that they admit the child for observation, and you as the nurse do have a duty, a legal right to report it. If we're looking at a late adolescent who is trying to leave her abusive partner, you want to note that some of these abuse situations get very violent, and if she does try to leave her partner, the partner may try to actually kill her. If you are assessing a patient for abuse, an appropriate statement would be telling the client that injuries like these do not usually happen by accident. Also, they shouldn't feel guilty because they did not provoke the attack. The following would be suspected of abuse if you are assessing the patient: cuts or bruises on the hands, burns on the hands, curved lacerations on the back, and linear lesions across the chest and the abdomen. Also suspect abuse if parents tell you that the child's injuries are because their older brother or sister plays too rough with him or her, and if the child has a burn that has actually not been treated. You want to note that those at risk for maltreatment could be those who are maltreated themselves as a child, if the child was born prematurely, or if the caregiver recently lost a job or any type of income. Note that those abused rarely report it because they feel some type of responsibility for causing that particular incident. And lastly, if rape is suspected, try decreasing their guilt and increasing their actual self-esteem. And that will conclude Chapter 36, which goes over child abuse and neglect. Okay guys, it is now time for a review. Please review these notes as well as any highlights that I pointed out within your text, and it may be helpful to answer the questions within the back of each chapter that serve as a review and outline for the chapter's objectives.